Right, Pauline, I've just sent it to go live.
Okay, the meeting is now live, everybody. So, Chairman, if you would like to commence, thank you.
Thank you, Paulina. So, good evening, everyone. Welcome to the House Scrutiny Committee. I would like to start by welcoming those members of the public and press who are watching live stream on the Peterborough City Council's YouTube page. Due to government guidance on social distancing, this meeting is taking place remotely in accordance with current legislation as laid out in the local authorities and police and crime panels coronavirus regulations 2020, which makes provision for remote attendance at and remote access to council meetings. The meeting is also following the Peterborough City Council's virtual meeting protocol. In order for this meeting to run smoothly, can I ask several things from all members and participants? Please keep your video camera switched on with your microphone muted, except when you are invited to speak. If you wish to speak, then raise your virtual blue hand located at the bottom of the participant section. I and the Democratic Services team will keep an eye on the participants list to see who wishes to speak. Please be patient. If you are not invited to speak as soon as you raise your hand, this may be because other people are wishing to speak before you. The Democratic Services team will be monitoring the participants list to see if anyone has dropped out of the meeting. They will try and contact you if you do drop out to provide assistance to help you rejoin. As with all new systems, we may run into technical problems, and for this I ask for your patience. Should this occur, an adjournment of the meeting will be declared or the fault is addressed, and the public broadcast will be paused. If it is not possible, the meeting will be adjourned until such time as it can reconvene. Finally, I would remind members that all virtual meetings are recorded. Before we move to the first item on the agenda, I will begin with a roll call of the Scrutiny Committee members to establish your presence. When your name is called, please unmute your microphone and confirm that you are in attendance. Thank you. Councillor Barkham.
Here.
Councillor Burbridge.
Yeah, I'm here.
Councillor Fowler.
Yeah, I'm here, Chair.
Councillor Hemraj.
I'm here.
Councillor Kayam.
Present, Chair, thank you.
Councillor Rush.
Present.
Councillor Sanford.
I'm here.
Councillor Simons.
Yes, present.
Councillor Warren.
Present.
Co-opted member Parish Council June Bull.
In attendance, Madam Chair.
And Susan Mahmood is also in attendance representing Health Watch.
Here.
Susan, are you here?
I am.
Thank you. We will now move to agenda item number 1. Paulina, could you give us the apologies for absence, please?
Thank you, Chairman. We have apologies for absence from Councillor Ali, and Councillor Fowler is in attendance as his substitute. Thank you.
Thank you. On to item number 2. Does any member of the committee have any declarations of interest or whipping declarations? Councillor Hemraj?
Yeah, I'm an employee of North West Anglia Foundation Trust, so I won't be speaking at all on this first subject. Thank you.
Thank you. Okay. So, on to item number 3. We are now being asked to agree the minutes from the House Scrutiny Committee meeting held on the 9th of March 2020 and the minutes of the Joint Scrutiny Committee held on the 20th of May 2020, as set out in the agenda on correct records of those meetings. We will take each set of minutes in turn. First, the minutes of the House Scrutiny Committee meeting held on the 9th of March 2020, pages 3 to 16 of the agenda. Can I ask if any member who does not agree that the minutes are a true record to click and raise your hand on the screen now, please? Okay, I see there's no objections, so I'll take it as the minutes are agreed. Item number 2, minutes of the Joint Scrutiny Committee meeting held on the 20th of May 2020. Councillor Bull, do you have something to say?
Yes, Madam Chair. Page 28, the very last. If only our treasurer did have those amounts of funds, so it should read Treasury rather than Treasurer. The very last line on page 28. As I say, if only our treasurer did have that amount of money, we'd be sailing, wouldn't we?
Sorry, Councillor Ball. Sorry, you cut out while you were saying the most interesting part. So could you just repeat the alteration, please, so that I can make a note of it? Thank you.
Certainly. Page 28, the very last sentence, it shouldn't read Treasurer, but Treasury. I made a humorous remark. If only our treasurer did have that amount of money, we'd be plain sailing.
Thank you. I'll make a note. Thank you.
Okay, are there any other objections to the minutes? Okay, then I will take the minutes apart from that alteration. The minutes are agreed. Okay, on to item number 4. The proposals for the relocation of the urgent treatment care and GP out of hours service in Peterborough, pages 31 to 42 on the agenda. I'd like to welcome the following officers who are in attendance to assist with the presentation of this report. Caroline Walker, Chief Executive, North West Anglia NHS Foundation Trust. Jessica Bowden, Director of Primary Care and Urgent and Emergency Care Collaborative Lead for CPCCG. Arthur Azin, Emergency Clinical Lead for NWAFT. Oscar, and I apologise if I get it wrong, Oscar Ayaguchi, Clinical Lead for Cambridgeshire and Peterborough for Hearts Urgent Care. Andrew Anderson, Clinical Lead for Urgent Care, CMP CCG. Tracy Pilcher, Chief Nurse, Lincolnshire Community Health NHS Trust. Ian Weller, Head of Urgent and Emergency Care, CMP CCG. Louise Mitchell, Director of Strategy and Planning, and Alison Lungley, Hearts Urgent Care. And we also have Janice Greenhill, Director of Performance and Delivery for Hearts Urgent Care, and Ian Hollingsworth, Integrated Urgent Care Services Manager for Hearts Urgent Care. So if I pass over to Caroline to introduce her report.
Thank you, Chairman. My name is Caroline Walker, Chief Executive of North West Anglia. On behalf of all the partners here this evening, I'd like to present agenda item 4 to you. The papers record our proposal to relocate the Urgent Treatment Centre and the GP out of hours service from the City Care Centre over to the Peterborough City Hospital. And within the paper, you've got the plans for how we consult with the public on those proposals. The co-located service as presented in the paper will provide a fully integrated service in its second phase, but the initial phase is to move the service on a like-for-like basis. So a lift and shift of the services from the City Care Centre over to the Peterborough City Hospital for the first phase. The paper also goes on to describe the 4 streams that we ultimately will provide for our walk-in patients that will give an integrated, improved service compared to the 2 different located sites at the moment. not recorded in the paper, but I'd like to make the point that there's no change for patients arriving in ambulances. This is entirely about patients arriving to the Peterborough City Hospital in future in a joined up co-located urgent care for walk-ins. The paper documents the consultation we're proposing with the public on this proposal, something we've been just trying to achieve for a long time, but it takes you through the timescales that we're proposing to do this. It also usefully uses the outcomes of the big conversation, the recent consultation that the CCG undertook with the public to talk about their needs and wants for the services that we provide. So that gives a useful context for the change that we're proposing. The paper's self-explanatory, and hopefully we can go on to answer all of the questions from the committee and for the partners. But the paper's requesting your views on the proposal, something that all partners around the table today are in support of. And we're seeking your permission to go to public consultation to do this. The paper fully explores the plans for that proposal, and everybody in the team's here to answer questions should that be necessary on any items of the proposal. Thank you, Chairman.
Councillor Aiken, you're still on mute.
Sorry about that. I had an issue with my microphone. So thank you, Caroline. So if you're happy, we'll go straight on to questions. And Councillor Kayam.
Thank you very much, Chair. Thank you, Caroline, for that presentation. And before I start, I'd just like to thank you and the hospital team for working admirably well during the COVID-19 crisis as well. And we're all very proud of you. I'd like a question, please, regarding this particular agenda. First of all, it's regarding parking. We know that parking is fairly limited at the moment for the current provision of patients that usually come to the outpatient services. That's my first question. So how are we going to accommodate that, please? My second question is that currently, out of hours service, the City Care Centre also houses the minor injury unit that has walk-ins until 8 p.m. Is this service, like you say, a like-for-like service? Is this going to be operating over 24 hours, whereby patients can access a GP for minor illness 24 hours, and thus obviously taking the pressure of the A&E department? We are supportive of it in the Labour group, and we're encouraging of it, but these are just two questions. Thank you very much.
Thank you, Chairman. I think I can take those and then anybody else can add. So car parking has definitely been an issue on the Peterborough City Hospital site, and I understand it's an issue on the City Care Centre site as well. Looking at the main presentations of some of the walk-ins and the time of day that they come, the vast majority of car parking issues come in the early evening, and we're definitely have plans to change our car parking arrangements on the Peterborough City Hospital campus. At the moment, we don't have any car parking issues, and we have lots of empty spaces as we aren't fully bringing all the patients to our hospital. But we think we've accommodated car parking requirements, and indeed the CCG have done an audit of when people come to the City Care Centre now for their services, and whether they arrive by public transport or by car parking as well. So it's something we've thought about, and it's something we'll need to keep our eyes on. But it's definitely looking at the times of day that people come. There should be adequate car parking on the Peterborough City Hospital site for patients. Thinking about the other services, at the moment we're proposing in the first phase of this to bring the services over to the City Hospital like for like. So that wouldn't mean that GPs were on site all of the time. It would be a similar arrangement to now. But our full intention is to move to something more integrated, where we've got the backup from all of the minors and the workforce that are currently in the minor stream of the ED department, along with the out-of-hours GPs and the advanced practitioners that support the urgent treatment centre minor injuries unit now. So it's definitely something we've thought about and we have a solution for.
Okay, thank you. Chair, may I ask a follow-up question, if that's okay?
Yes, that's fine.
Thank you very much, Chair. I'm assuming that such processes will further be audited, especially in regards to parking, given that I do have, my husband works at the hospital. Sometimes getting out of the car park area towards rush hour time can be tremendously difficult, as well as peak hours in the morning as well. So putting that in mind and putting your valuable staff in mind, I'm assuming that you will be auditing the process and following up after that as well.
Yes, it's something we do worry about. It's something I worry about, the peak times, and our plans for expanding car parking and our green travel plan do accommodate some changes to patient flow and activity on that. At the moment, there are no issues leaving the site and no issues arriving on the site because we have less patients and have moved to digital arrangements for lots of our patients who would have come at peak times. And we've also got lots of staff working agilely at home as we're not bringing all of our staff to site on a daily basis either. So something to keep an eye on and keep looking for, but I'm well aware of the issues that you mentioned.
Thank you.
On to Co-optee June Bull.
Thank you, Madam Chair. Personally, I welcome this initiative to have a single point access and be co-located. Obviously, the idea is to have this go ahead before winter 2020 and after the 8-week consultation. The thing I really like about it is patients no longer will have to decide how serious their illness injury is, as clinicians will determine this via the 4 work streams. But the PCH site has, in my view, only adequate public transport, and parking, as already mentioned, is a real issue. And where on the site will UTC be located? The site's already densely populated. I'm just curious as to know where that will sit.
So I'll probably take that one again and then others can help. But we're intending to bring the service right into the front of the ED department, where we have our waiting room and our walk-in patients first enter the department. We do have planning permission to put another building next to that if we wanted, when we originally thought we were going to move GP streaming services to the site. But at the moment, we think we can accommodate it within the template of the floor that we've reconfigured to provide same-day urgent care, and combine it with our minors stream as people enter through the same door, the non-ambulance entrance to the hospital. So we think we've accommodated it. We've designed a floor plan that will cover everything, and it will be right at the front of the ED department. And as you say, our intention is that that we've got the same access for all patients coming, and then we help them make the decision whether they access GPs or advanced practitioners, or they come straight into the department based on their clinical presentation.
May I just ask a supplementary to that? Will the consultation include the map of the footprint of the UCP? And who's going to answer the question about public transport? And yeah, that's it, really.
We can include some reference to the how we anticipate the patient flow and the arrivals working. And this comes hand in hand as well with national thinking, that most people need to arrive at the department with a scheduled time slot as well for their arrival, especially in a COVID world where we don't want people sitting in a waiting room for a long time. So there's new thinking coming into how we plan to do this. But yes, we can include the floor plate and how we're thinking the department will locate itself in the consultation. I'm not sure I'm the best person to talk about the public transport, but the public transport to the hospital is adequate at most times of the day. And that review of presentations at the City Care Centre did reveal that not many people actually use public transport to come to the City Care Centre already. And it was a very small number of the presentations on a daily basis that did use public transport. I think Andrew Anderson is trying to come into the conversation.
Go ahead, Andrew.
Yeah, sorry. Obviously, we did a similar exercise in Cambridge a couple of years ago with relocating GP out of hours to co-locate with the ED department. And we did do some work and research prior to that, so I think we could probably do that here if we haven't already got the data, which is how people attend for their urgent care. And the people who actually attended on foot, bicycle or public transport was very, very low. And most people attended in a car, because if they get a prescription, the onward journey to a pharmacy is often, that's not on site either. So the way it all works is quite difficult. But I think that's some work we could do in terms of how do people attend for their emergency care appointments, both ED, UTC, GP out of hours, and that might reassure you that actually the public transport isn't a massive issue, because they will often come in a car.
Okay, thank you, Andrew. Caroline, is there any follow-up, or you happy with the reply?
I'm happy with the reply, thank you.
Okay, right, on to Councillor Burbridge.
Hi, thank you, Chair, and thank you guys for the very conclusive report. I'd also like to add my thanks for all the work throughout the COVID situation as well. I've got 2 points, and both have really been covered at the moment, but I'd just like to go into a little bit more in detail. With the parking situation, as a councillor in Bretton in particular, and a resident in Ravensthorpe, I can say that whilst the parking is at a premium on site, one of the main issues, particularly in Bretton and Ravensthorpe, and also Netherton to an extent, is that the parking is overflowing now into residential areas. Many residents are now finding it very difficult to park in their own streets at all times of day, because we have visitor and staff parking in the residential streets, and I've actually seen this come to blows and actual confrontations between people trying to park and residents trying to come home and park their vehicles in the evening or get out in the mornings. So we were promised that there was going to be an expansion of car parking on site at PCC. Is there any update to when that's going to happen with timescales? And the second one is also on the accessibility. What we're doing is removing the out of hours and drop-in services from a central location to effectively one side of the city. Obviously, we're ideally placed in Peterborough because we have a ring road that goes all the way around the city, but all buses go to town before they come back out again to Bretton. Would it not be an idea to consider some kind of arterial bus route to go to all the major outlying areas of Peterborough and dropping at PCC, which is on the A47? Thank you.
Thank you. So I think I'll sort of reiterate my point about our green travel plan and our expansion plan. We do have plans as a hospital site to have another significant amount of car parking in the form of a multi-storey, and we do have plans that we've spoken initially to the council about around having another exit from the site, something that we'd like to achieve some of that congestion. And it is regrettable, I'm sorry to hear that visitors park on residents with residential areas. I have to say at the moment though, there are absolutely no car parking issues on the site, and there are hundreds and hundreds of spaces free every day, because we're not, in the pandemic, we're not allowing many visitors to come to the site, and then our activity isn't as it was, and as I said previously, our workforce are working agilely from home for several hundred of them every day at the moment. So it's something we need to come back to, but we do have plans drawn up and arrangements to, as part of our green travel plan, to have more car parking, but also to allow less staff to come to site with their cars as well, who live very locally to the hospital.
Okay, so next is Councillor Sanford.
Yes, thank you, Madam Chairman. I'm slightly concerned about this public transport access, because this is one of the things I was going to ask about. I think I saw some statistics a while back that said around about 30% of the population in Peterborough don't have regular access to a private car. So it seems to be that we're reliant on some research that's been done in Cambridge as to what the likely numbers of people accessing the service by public transport is. Now, I think the optimal place to have an urgent care centre for people with using public transport is actually in the city centre. And have you taken account of the fact, for instance, that somebody living in parts of my ward in Paston, where quite a lot of people don't have cars, could have to make a journey in order to get to the hospital site, to go to the urgent care centre, could have to make a journey into town then make a journey out again. And, you know, in the sort of evening period, that becomes problematical because the bus services at Queensgate don't all connect. So somebody could not only have to make quite a long journey, but have to spend quite a lot of time hanging around in Queensgate. So I don't detect from what you've said that you've done much research into, you know, the difficulties that people will have in accessing the service by public transport.
I think Andrew would like to come in on that one.
Sorry, Nick, probably misunderstood me. What I said was that we did, for the Cambridge move, we did just that audit. And what I was offering was that perhaps that we should do that audit in Peterborough, because you're quite right, it could reveal very different figures. But I was just using that as illustrative of what we could do is as part of the consultation is, and I think we should do it, is, you know, what percentage of our footfall uses those various models? Because although people, my experience certainly working out of hours most Saturday and Sunday night, is that people, although they don't have regular access to a car, usually have a friend, neighbour, family member who are quite happy to convey them to the city care centre in a car, you know, when they're ill. So I think we definitely, it sounds like we need to do that audit for Peterborough as part of the information we collect in the public consultation. So I'm hoping the results would reassure us all that the public transport is not perhaps such a big issue as we feel it might be, that's all.
I think Ian was wanting to come in, and possibly Jess, if you want to add to that point.
Yes, I think that it's right to raise those concerns. I mean, we have done some audits at the City Care Centre. So one of the things we wanted to understand is how people present at the City Care Centre, whether they come whether they walk locally, whether they walk from the City Care Centre, from the centre of town, which was a concern raised, or take the bus or taxi. So we have done some survey work, and what we found was that 99% of people actually come in their own car. And when we interviewed those people at the City Care Centre, there was quite a lot of complaints about the car parking at Thorpe Road, and actually only one came in on the bus. So we're more comfortable with the fact that we're not making access harder. We've also looked at, as part of the overall impact assessment, around access by the public transport. And there are some, as you're quite right in pointing out, that the buses go into town and then out again, but there is a good service of Stagecoach, provide a good service in and out of the city to the hospital site, and the buses run about every 12 to 20 minutes. So there is a good service and a good coverage from the main city centre to Peterborough City Hospital. So these things have been done as part of the impact assessment.
Could I just come back with a supplementary question on that?
Yeah, of course.
Yeah. I was talking about the problems people might experience in the sort of evening period, but I think there's also, as people have alluded to earlier, there's a problem of congestion on the site. And okay, in the current COVID emergency period, that might not be a problem, but it certainly has been a problem in the past, even to the point that at peak hours, the local bus company has actually decided that for 2-hour periods in the morning and evenings, they don't take the buses all the way onto the site. They just go to the bus stop at the end, and that is because of congestion. So I think that I'd be really interested to see what's in your green travel plan, because I think, you know, trying to divert some of the people away from using cars would be a good thing. But I think there's a danger. I can see lots of positives from this, you know, people having all the services in one place. But I do think, you know, if you're piling more and more people onto a site that has already historically had issues with congestion, I think there maybe are some problems there.
Okay, I just wanted to check, Jess, was there anything that you wanted to follow up on at all?
No, just I think what we need to do is publish those impact assessments, do the work that we've done, the survey work, as part of the consultation, so that people get to see the full picture.
Yeah, okay. Thank you. So on to Susan Mahmood.
Thank you. Caroline, I've read the report in detail and it is extremely good. But speaking for Health Watch, going right back to basics, we wonder why you are moving from a small non-hospital site to a busy hospital at this time. We know how people feel about COVID, how frightened they are to go to the hospital, and we appreciate that everything is being done by hospital staff to keep the place safe, but people are still very worried, and I think many of them would prefer still to go to a non-hospital site. And secondly, we query how relevant consultation is at this point, because Health Watch won't be doing face-to-face engagement at the present, nor in the foreseeable future. And therefore, it won't reach people who are not digitally connected. And they are the people most likely to be affected by the move.
Okay, can I ask Jessica to take that one? I think the plans do involve extensive digital arrangements, but I'm not sure about the specifics on Health Watch.
And I might bring my colleague Louise, who's also on the call in. So I think you're right to be concerned around, we haven't consulted in a period like this before. What I would say is that previously in the consultations we've done before the big conversation, which we came to talk to you about and not so long ago, the face-to-face consultation elements were probably the least well attended. Working through organisations and advocacy organisations such as Health Watch and other groups actually is a lot more effective, and the digital platforms have really increased our engagement with the population, bearing in mind that not everybody is on those platforms, and that's something we're going to have to make sure that we reach out through their advocacy organisations to do that. We're still considering whether we should be producing publishing actually paper documents. We think probably not, given infection prevention and control, but I think we just have to think very carefully that we make sure that we reach out in the best way that we can. But having said that, the digital platforms really are increasing our reach, because even if somebody doesn't have access to it now, their friends and family do as well. But I take your point, and we're going to do our best to make sure that we can get to as many people as possible during this period. Don't know if there's something you want to add, Louise?
Yeah, I just echo what you've said, Jess, and I think the other thing that we need to do, even aside from this, but generally, I've just seen another comment on the chat box about, understandably, the public's concern about accessing hospitals at the moment. So we're also doing some very proactive work and need to continue to do that, particularly where people do need to be accessing hospital to benefit their own health. So I think there's something that's sort of hand in glove with that as well. But I think it is really pertinent that you've flagged, Jess, that actually the digital platform, certainly in the big conversation, worked extremely well. And again, I think we'd just reach out if people have got other ideas about how we can again proactively engage through the consultation with either hard to reach groups or use other medium, then please do tell us, and we're very much open to that. Thank you.
Okay, so on to Councillor Flower.
Thank you, Chair. I sort of the first comments are, well, I've got two, to be honest. I've got the first comment relates to this issue of transport, which I know that my colleagues and Councillor Nick Sanford have briefly mentioned, because I understand that, you know, there is obviously a popular side of car usage in the city, but I also recognise that we are here at a health committee, and therefore we should be doing as much as we can to advocate alternative modes of transport. I noted that Councillor Burbridge mentioned about the idea of some sort of enhanced bus scheme, which I think is a very good idea, because put simply, you know, whether or not one of the people who presently uses the centres, say down Thorpe Road, is the only one who doesn't travel in by car, that doesn't really matter. And the way this came across a second ago, if I'm perfectly honest, it was almost as though certain speakers were almost boasting about the fact there was such a limited number of people who don't use the car. We've got to think about going forward, and we've got to think about making the option, if it is going to be moved, of reaching this venue, you know, accessible just about to anybody, while maintaining this aspiration that we have as a city to become the environment capital. So what I would say is to these people who are here today, within this green plan that you've spoken about bringing forward, are there any real solid viable plans for an enhanced bus service, a more reliable bus service, and the enablement of, as I say, alternative modes of transport to the car? Thank you.
Perhaps I could address that one. The green travel plans for the hospital, and it does include working with the bus companies to provide alternative routes and more options, which is something our staff have asked for when we've expressed the opinion that they don't bring their vehicles to site as well, and the public have asked for that as well. So it's definitely something that we've spoken about, and we've encouraged as part of the green travel plan. We do encourage patients not to bring their cars to site if they can avoid it. I do need to be clear though that whilst I acknowledge that fear is a factor at the moment, significant amounts of patients are still coming to the hospital every day, and our A&E attendances at the moment are 85% plus of pre-COVID levels. So patients are coming back to the hospital. We need to do all we can to get everybody to use public transport where they can, and that is a big part of what the trust plans to do, but that needs to be done in conjunction with the council as well, with bus routes and permissions for alternative routes to the hospital.
Okay, I might get my second question, Chair. Is that okay?
Well, just bear with me a second. Andrew's just got a follow-up, I think.
Darren, just a comment. I mean, we're talking about people moving for a face-to-face consultation. I think what we've found in the last 6 months, as Caroline's alluded to, and we've experienced that in general practice in out of hours, is we're doing an awful lot of consultations now remotely. We're using video consultations. I didn't have one of these cameras 3 months ago. COVID's given me a webcam here today, and like most of us, we'd all be meeting in a room. I think the health service is going to change following this. I think we have learned there's a different way to do our work, and it doesn't mean people driving around and doing stuff. Electronic prescriptions, which we were told were not possible in out of hours, COVID has made it now possible. And we can send prescriptions to the pharmacy nearest to where you live if we can deal with the condition remotely. So I think the health service and all of us have got a lot to learn about how we deliver healthcare. So there is a national agenda about 111 first, where we're encouraging people to ring 111 initially for an assessment. And if we can deliver a remote assessment safely that delivers that healthcare over the phone or video, then we're doing that, which negates the reason to drive up to a building to see someone face to face. And the other thing we're looking at is how we, through that assessment, getting direct booking. So you will have a booked appointment in the urgent treatment centre. So rather than turning up and sitting in a crowded waiting room in a long queue, you will turn up for a booked appointment and you'll be seen on time, which also will help, I think, reduce congestion, because we can even out the flows and match it and align it to our workforce. So these are all green plans, I think, that don't necessarily involve burning petrol and moving people around, but actually just rethinking about how we deliver healthcare in the country. So just a few things to think about.
Councillor Fowler, if you want to come back. Oh, Jess, did you want to say something?
Is my hand still up?
No,
so I thought
it's all right. I just wanted to check you didn't want to come back at anything. So
no, that's fine. I'm just answering Councillor Kyan's response there.
Okay, no problem. Councillor Fowler, if you want to say your supplementary.
Yeah, so well, it's not really a supplementary, it's a cheeky second one, to be honest with you. It's a simple one. It's just a query as to when phase 2 will be taking place.
I think Jess has just posted that on the chat, but we're wanting the first phase to embed and to get safely through winter, and then hoping that we can move to the integrated further phase probably by the spring, is my understanding.
That's right.
Chair, just a supplementary there, if that's all right. I didn't realise it had been posted on this chat section. I'll have a look at that in a second. Is the chat section available, Chair, to the members of the public as we're having this meeting right now, just for openness?
Thank you for mentioning that. Could you request that people obviously ask their questions in the public domain and not in the chat section, please, and responses be given in the public domain so that obviously members of the public can hear. Thank you.
So in which case I'll just add to say that what we'll be doing is evaluating the phase 2, and if all has gone well, then it will be after the winter period that we'll be implementing phase 3.
Okay, Councillor Barkham.
Thank you, Chair. With regards to consultation element of this, there may be some members of the public watching right now, and people have contacted me previously with regards to consultations and a lack of confidence in them with regards to if people do contribute or put comments forward or in opinions, they've not taken into account or ignored, doesn't change anything. Are there any factors from the consultation that could actually affect the model? Could it be stopped, changed from opinions or comments on the public, for example? That's the first part of comments. And the second part, just regards to transferring the UTC to the hospital, what would then be used with the offices or the building or where it's presently located? What is the plan to be utilised for that? Thank you.
Possibly Jess might be the best one to answer about the public consultation, or Ian, and then maybe I can comment on the use of the City Care Centre afterwards.
So the answer is yes. If people have raised questions of things that we haven't thought about, which often happens, I have to say, about access or understanding of how to use services, then we'll change things. We have changed things in the past. Also, so the second part of your question was, remind me, about the City Care Centre. You can answer the City Care Centre, Caroline.
Yeah, so we don't have a full proposal yet for the use of the City Care Centre. We're trying to address the clinical need of the urgent out of hours and the urgent care through this solution. But what we know is that we're working together in the north of Cambridgeshire to come up with a solution. Our direction of travel involves having community and primary care hubs together, co-located, in line with the long-term plan of the NHS. So our assumption is that we'll, after this transfer has successfully happened, we want to keep it open for a while in case we have to change any arrangements and bring back different services. But the intention is to then think about what the best location is. So it will still be a health facility, but it might be from an integrated primary community care hub in line with the NHS plan requirements.
And just to reiterate that the UTC is only at the front of the building, so it's only part of, there's a lot of other health facilities and clinics and inpatient wards at the City Care Centre. So there's no plans to get rid of that facility. We need to use it more, in fact.
Okay, so just very briefly then, there's no necessary plan in regards to what to use with the existing area that's utilised by the present UTC. And the consultation, are there any circumstances in which it can be changed? Because you didn't really, you said yes, but if people want to put comments forward, what would it actually take for this to either be stopped? For example, people mentioned comments about transport, such as parking issues, getting to the site. If enough people come forward with a problem, would that then affect this model and it would either be revised completely, as in doesn't get moved? Is there a circumstance could cause it not to be moved, is my question.
So consultations in the past have changed what happens. I think that some of you might have been on committees 10 years ago. And so, for example, when Alma Road was closed, the change was quite considerable change following consultation around that. So there was a closure. We had a nurse-led unit and we had GP-led unit, and there was a plan to close the GP-led unit, and following public consultation we merged the two, so that was a GP and nurse-led unit at the UTC. So yes, we do change what we're going to do. I think it will depend on the strength of feeling and also the options that, because quite often the public put forward options that we haven't thought of. So actually it's looking at what people say and what they suggest would be really helpful. And what I would also say is that we're also talking around with the staff. So that's really important that the staff are consulted with around this, because it's a different way of working. And there's a whole piece of work going on with staff and trade unions around, does this work for you? How are you going to work alongside colleagues? How the patient's going to interact and how's that going to work? So there's a lot of work to be done over the next couple of months. I absolutely agree with you. And we need to take account, and things can change and will change if they need to.
Thank you, Tim.
Okay, so I'm just conscious of time, and we've had a good discussion. We've got Councillor Rush, Councillor Sanford, Councillor Kayam and co-optee June Bull. And I think then that'll be the questions for this paper. So we can go to Councillor Rush.
Thank you, Chair. For many years now, this committee has been discussing the City Care Centre and about moving it to in front of a hospital. Jess alluded to when the Alma Road Centre was closed down, a lot of patients presented themselves at the A&E department because that was the obvious place for them to go. It wasn't the obvious place to go for some of the patients themselves. So we have been asking for many years to have front of house people at the hospitals so they could be signposted. There's been a lot of talk about parking. I've been to the City Care Centre between 9 and 9:30 for blood tests, and that car park has already been full that time of day. Bus services, I think there's a better bus service to the City City Hospital because you have a number 2 and number 3. So I personally think that it's at the moment it's a better service than what it would be the City Care Centre. So I am very supportive of this proposal. One question I would like to ask is about appointments. How would people make appointments? Thank you.
I think possibly Andrew might be the best person to talk about that.
Thanks, Brian. So I'm one of the regional clinical leads for the East of England, where we're starting to pilot direct booking into EDs and urgent treatment centres, and a service called same-day emergency care. So basically, you ring 111, you get an assessment. The result of that assessment is that you need to go to ED. So rather than saying just go to ED or just go to the urgent treatment centre, that you'll be given a timed appointment. Often a lot of the things, like I've fallen over, I think I've broken my wrist, you don't need to go now. An hour or two down the line is perfectly satisfactory. Hopefully you'll be seen on time. If you go to the City Care Centre, where the out of hours and the urgent treatment centre are co-located, that waiting room is often packed on a Saturday and they're queuing out the door. The vast majority of those patients are waiting for the urgent treatment centre, which currently is a walk-in type service, rather than the out of hours where only 1 or 2 patients are waiting for that. So I think, once we can start to move all these services to booked appointments, getting people to ring first, we can get them an appointment at a time that is clinically safe, and they'll be seen on time. It will reduce overcrowding in our ED departments, and that is a sort of national agenda about think 111 first, and it's part of a work stream that we're starting to develop right now. So I'm quite enthusiastic about it. I've been champing at the bit for 4 years and finally persuaded the powers that be that maybe this has some mileage in it. So I just think it'd be so fantastic to get an appointment in ED and you go there at 4 o'clock and by golly, you're seen at 4 o'clock and you're out the door by past, rather than sitting around for hours on end. And I think most public that I talk to are actually quite enthusiastic and would love a service like that. But it will mean ringing first rather than just turning up, because people who turn up often, as Attar will attest to, don't really need to be in ED. They could be seen by a GP type service. But if we get them to ring first, we can get them in the right service that best meets their needs at a time that's convenient to them as well.
Can I just come back to that, Kim? I
Yes,
totally agree. Yeah, sorry, I totally agree with your reckoning. It's better to make an appointment to know when you're going to go and we're going to be seen than to sit there for probably hours on end just waiting. So I certainly agree with you. Thank you very much.
Okay, so I just want to check. Tracy, you put your hand up. Is there something you wanted to say?
Yeah, I just want to reiterate that model. We run it in Lincolnshire, so we have urgent treatment centres located at the front door at Pilgrim and Lincoln. It's integrated. Patients ring first, we book them through 111 into either the urgent treatment centre, and we started to look at booking into Estec as well. So there is that kind of model that's operating in Lincolnshire already. We have used significant video consultations. So I think in terms of a working model, we have got a lot of benefits and we have demonstrated the impact on the public in Lincolnshire as running that model.
Good, thank you for that. Attar, I see your hands up as well.
Yeah, just to clarify on one of the points that Andrew mentioned, with regards to appointments booked ED, what we mean is a patient will be booked into an appointment because at the end of the day, patient needs to be seen, and the patient will be seen by an appropriate clinician. So because the UTC will be located at the front of ED, so you will be booked into an appointment in the urgent treatment center, because emergency department, what we want is real emergency patients who come to emergency department who will be seen, who are critically ill patients coming via an ambulance. So the booking will be mainly to the urgent treatment center so that you get an appointment and you come at that time and be seen by the clinicians.
Okay, thank you. Councillor Sanford.
Yes, thank you, Madam Chairman. Sorry for coming back a second time. I do think there are a lot of positive aspects of this proposal, and some of the things that Mr. Anderson has been saying about, use of more telephone appointments, giving people fixed appointments. I think that's really good. But I do concur with some of the comments that Councillor Farrer made about the possible transport implications. And I know Caroline was saying putting a lot of emphasis on the green travel plan, but I think I would like to see the green travel plan, because if the green travel plan involves real funding being put into making public transport improvements, I think that's really good. But if it's all about aspiring to do things, that's not so good. So could I ask at some point, could the hospital green travel plan be brought to this committee so we can have a broader discussion about what's actually in it and whether we think it's going to be effective? Because I think whatever you think of these proposals, it is concentrating more services at that hospital location. So I think that is potentially going to have transport implications.
So who wants to pick that up? I don't know whether it be Caroline or Jess, but
no, it's me. I can commit to come back and talk you through our aspirations and the reality of some of the things we're doing on the green travel plan, which is something that we've approved as a hospital at some point last year, and is publicly available. So I'll talk the committee through what the phases of what we intend to do. Some chunks of it have changed in the COVID world, but most of it is still valid with the green aspiration.
Good, thank you. Paulina, can I just check with you? Do we need to put that down as an action or recommendation? You're on mute.
Yeah, sorry about that.
That's all right.
No, I've got it down as an action to come back to the next meeting of the Health Committee, which will probably be in September.
Lovely, thank you very much. Okay, Councillor Kyan.
Thank you, Madam Chair. I would just like to go back on the points that Dr. Anderson had raised regarding the change of working. And I certainly concur with him, being a GP, and the way we have started to work now through virtual webcam has enabled us to actually speak to double the amount of patients that we would have interacted with if we saw face-to-face appointments. The concerns that I have around that only are the fact that we are yet to learn the implications long-term of COVID-19, especially in light of cancer diagnoses, etc., which is something that's going to become more apparent as time goes on. Therefore, my question was that, do you think that there is a scope to improve the quality of triage at NHS 111, for example, rather than having call handlers have clinicians, ANPs, etc.? And as a result of this shift, will there be any redundancies? Thank you.
Caroline, is that a question?
It's for Andrew, that one.
Yeah, thanks, Shabina. I'm not sure if you're aware, but I was one of the first 111 services in the country to put GPs in the call centre, much to the disgust of NHS England. And very quickly we proved that having GPs supporting the high-end dispositions, the ED and the ambulance, has made a huge impact. So I'm fully behind you. We're currently exploring the CAS is the clinical assessment service. So that's the bit that sits behind the pathways assessment. So I think we need the initial filter just to deal with the volume of calls. and then where it's appropriate, we map those to the clinical assessment service, who make the decision as to where the patient needs to go. And that CAS is expanding. We've got pharmacists in it now. We're even starting to look at whether paediatricians might want to be part of that clinical assessment service. I've even got A&E consultants in Cambridge champing at the bit, wanting to come and work in the CAS. So we are looking at all of those options. As you know, we are a pioneer site for the 111 option 2. So mental health services, rather than putting them through that pathways assessment with non-trained, well, they are trained, but not clinically trained, go straight to a mental health care professional for an assessment, and patients press that option 2. That again, that is a first that we did in Peterborough. Myself and one of my colleagues developed that. That is now going to be the national plan. So everyone's thinking this is a really good service and this is what we should all be doing. So I think we are often at the forefront with some of these things, Shabina, locally. And you know, I think it's because we've got an enthusiastic team. We've got a provider who's keen to embrace change and look at some of these things. And you know, I'm full of crazy ideas sometimes, but you know, sometimes they work out quite well. And I think it is about delivering some of those things. But yeah, we're looking at expanding the clinician stuff all the time. I don't think there'll be any redundancies in the health service. I think we need more people, not less, frankly, to deliver healthcare going forward in this country. Anyway, I'll shut up now.
Yeah, fantastic ideas. Thank you. Very encouraged by what you've had to say. Thank you.
Jess, I noticed you've got your hand up.
Yeah, so I was going to say something very similar. You know, these are very valuable staff to us. There's no plans to make any redundancies. We have a system that's short of these qualified staff. And just to sort of thank primary care, because primary care during COVID has been looking after the clinical assessment service. So calls have gone through to primary care, and they've been supporting 111 through COVID. So yeah, just support what Andrew said.
Thank you.
Okay, so last question from Co-optee June Ball.
Thank you, Madam Chair. It's about page 37, 6th bullet point down. I'm just wondering why Lincolnshire Health Scrutiny isn't included as consultees, as places like Stamford, Ufford, Wittering, Bainton, etc. form part of the Peterborough City Council geographic area. And also, why not add Peterborough Parish Councils, who have a real feel for what's happening on the ground?
Possibly Jess can answer that. It's something we could consider.
I know that they're on our list, but they're not on that bit of paper. So they always are. We always go to those committees if they want us to. Quite often we're just corresponding members of those committees, and they send comments through if they want to, or they say they don't have any comments, but point taken. And parish councils as well, if they're meeting, of course. But yes.
Can confirm parish councils are meeting.
Good.
Via Zoom.
Excellent.
Thanks for that, Jess. Okay, so now we come to the end of questions. I just have one, and that's with regards to when we will potentially see the results of the consultation. And I'm aware we obviously have a committee meeting in September, but are you actually going to have enough time to be able to prepare something in time for our meeting then? And
yes, that's me.
Caroline or Jess?
Jess, presumably, that's our intention, I think. Yes.
For the September meeting will be the interim, because I think we have to have papers in quite early for you. So it might be, I'm just wondering whether we need to do something virtually. So we're thinking beginning of August. So that would only be an interim report. So
yeah,
we were thinking of our governing body the first week of October. Yeah. So I just think we might need to manage how we share all of that.
Yeah, that's what I was thinking. Having you know, been part of consultations before, I was thinking that you wouldn't necessarily have all of the detail, but yes, an interim would be good so that you can at least bring us up to date with what's happening. What I would also say, and what I've said to committee members before, is obviously it's also our job to make sure that that consultation gets out to the residents of Peterborough. So Councillor Burbidge, as you've alluded to, obviously Breton has an issue. So again, we as councillors, we need to make sure that we do what's necessary to make sure that residents get a chance to sort of fill in the necessary paperwork. we can help them as much as possible. So with regards to the recommendations for this report, it was to discuss the proposals within this paper and to endorse the proposals for public consultation, which was Appendix A, regarding the relocation of the Urgent Treatment Centre in Peterborough from the City Care Centre to Peterborough City Hospital. So what I would ask is, do the committee agree to endorse the proposals for the public consultation? If you believe that by raising your virtual hand, if you have any objections, otherwise we'll agree to endorse it. Okay, that's good. All agreed. Thank you, Caroline. Thank you to all the other officers that have joined us tonight. We really appreciate you taking the time. And as normal, Caroline, Jess, please pass on our sincere thanks to all of your staff. They're doing a fantastic job. Tell them that it's not going unrecognised, and you know, we're here for them as much as we can be. Thank you.
Thank you for your support.
Thank you. So those officers now will leave the meeting, and we can now proceed on with the next section.
Councillor Hemraj can rejoin the meeting as well.
Yes.
So if you'd like, Councillor Hemraj would like to put your video up. Councillor Hemraj, are you there?
Yeah. Lovely. That's
great.
Thank you. Okay, so now we can go on to item number 5, our second paper of the evening, and that's the NHS England and NHS Improvement East of England response to COVID-19 and the delivery of NHS dental services in Peterborough, pages 43 to 46 on the agenda. So I'd like to welcome the following officers who are in attendance to assist with the presentation. And that's David Barter, Head of Commissioning for NHS England and NHS Improvement East of England, Tom Norfolk of the Local Dental Network, Chair and Lead Dental Practice Advisor, NHS England and NHS Improvement East of England, and Jessica Bendon, Senior Contracts Manager Dental, NHS England, NHS Improvement and East of England. So welcome, David. Again, if I can ask you to pretty much do what Caroline did and try and guide us through if there's any of those particular, if Tom or Jessica need to speak, I'll leave it in your hands to take it away.
Thank you, Chair. Well, we're grateful to be here this evening and have presented a kind of update and outline paper. I think one of the areas most affected in COVID in primary care has been primary care dental services. The Chief Dental Officer back in March declared that all non-urgent primary care dental activity should cease. Particularly with dentists, they work 6 inches to a foot away from the patient's airway. And of course, with the drills, they create aerosols called aerosol generating procedures. So it becomes very less safe for patients and for the dental team. So effectively, there was a cessation of regular dental care across England from the 25th of March through to around the 8th of June, when the Chief Dental Officer allowed practices to start to prepare themselves to reintroduce services to patients. During that hiatus, most practices were providing AAA, so advice, anesthesia, antibiotics, to patients remotely. And then we created some urgent care dental centres, which were volunteer dental practices that had the right level of PPE, personal protective equipment, up to level 3. So the levels that you would see very much so in the hospital setting. and they therefore could safely see patients. But obviously the number of those practices was limited, and the supply of PPE was for a time a limiting factor. But we successfully, and we were one of the first regions to have these urgent care dental centres become up and running. There are some obviously in Peterborough. They're kind of strategically placed across the region. But in reality, we went from, in our region, over 600 operating dental practices down to what we have now, which is 60 urgent dental care centres. So obviously a greatly reduced face-to-face opportunity for patients to see treatment. But now, post the 8th of June, many dental practices are getting up and running. But under advice from the Chief Dental Officer, the procedures that they're undertaking are mostly non-AGP, non-aerosol generating procedures. And so patients shouldn't expect just to go in for routine checkups at the moment. That will come in time, but as dentistry reopens, we have to make sure that, first of all, it's safe for patients and for the clinicians and their clinical teams in the practices, so that we don't or aren't part of any of the cause to spread COVID-19. The paper talks a little bit more in detail than my overview, but obviously we're happy to take questions.
Okay, so Councillor Fowler first.
Thank you, Chair. I think it's, page 44 of the report. It talks about 2 urgent dental care centres were put in place in Peterborough as a response to the initial restrictions. Now, I don't myself remember seeing this promoted or highlighted, and the people I've spoken to simply have said that, you know, over the last few months they phoned up dental practices and basically got told they're not taking on NHS people. So I'll be interested to know what work was done on that element. And supplement, well, not supplement, but a sort of semi-similar question relates to the point afterwards, where it talks about the East of England did not receive any complaints from dental patients in Peterborough. And again, I'm just trying to find out, how were people expected to complain? What was the process, and how were they notified of its availability? Thank you.
Certainly, thank you. So the gateway really into treatment in the urgent dental centres, urgent care dental centres, was effectively through either patients going to what would be their routine practice, and if that practice was closed and they did need urgent dental treatment, they could be referred by that practice to an urgent dental centre, or by calling 111, they could also be referred into the urgent dental centre as well. They would be triaged dependent upon their level of need. If not, they would be supported by a dental practice remotely and given advice, antibiotics, prescriptions, or anaesthesia in terms of pain medication. Perhaps I could let Tom Norfolk, who is the local dental network chair and a practicing dentist and a clinician, maybe explain a little bit more in detail about how that process occurred.
Yeah, thanks, David. Good evening, everybody. Essentially, as David said, when things shut down, they really shut down for patient safety purposes. So we set up a system which meant that when a patient phoned up their practice, or any practice, because they were approaching any practice, or NHS 111 or any of the systems there, everything eventually it came to the clinician doing one of 3 things: advice, analgesics, or antibiotics. And if it couldn't be stayed by that, i.e. done remotely, not face to face, then if that wasn't appropriate, it would then go on to the central triaging system. And we had a volunteer group of, I'm trying to think of the number, somewhere 50, 60, 70 dentists across the region, are often sort of working in shifts, 12-hour shifts, taking the referrals in, contacting patients, either doing it by video link or by telephone, again going through the AAAs, and if it was felt that that wasn't appropriate, by linking with other surgeons, other parts of other dentists then they could refer them to one of these urgent dental centres. Now, we didn't, and we still don't, advertise where these urgent dental centres are, because if it does get out, and in some parts of the country it has got out, they have queues round the corner, they have people banging on the doors, it's not safe for their staff. There are real sort of patient safety issues when that happens. So it was an internal referral system. And basically the advice, the very strict advice, was that we should avoid face-to-face contact with patients unless absolutely clinically necessary. And the bar was raised, and it was raised beyond the sort of the pain level. It was raised to the sort of, can we control the infection? Can we prevent these cases needing to be emergency cases in hospital? And so we were doing a lot of the work that hospitals would normally see. We're keeping them out of hospitals as much as possible. That situation has improved, but it's still very difficult out there, because a lot of the work we do generates this aerosol, which David has highlighted. And these aerosols are basically relate to the size of the droplet particles. So when we use a drill or a scaler, particularly the drill, the whizzy drill, the one that's the air generating, the one that you hear the air whizzing around, it generates a water particle that is the right size for COVID to stick to, for a better word. That then goes up in the air and in the atmosphere in the room. And it makes it very easy for anybody breathing that in for COVID to go straight inside them. And that's not aligned for the fact that the clinical team is working, as David said, half a foot away from the head. And so I think dentists and dental team are one of the highest, if not the highest, risk group of healthcare professionals seeing patients. So we've had to limit the care. It is improving. Dentists are opening, as David said, from the 8th of June, they could open, and the vast majority of practices now are open to do some level of care, whether it's the AGP stuff or non-AGP, depending on how ready they are, how safe they feel. And slowly but surely things are coming back, which means the UDCs are being used less now. So we're finding that the numbers of patients coming into the UDCs is reducing because they're able to get the normal care from their dentist. And so we're going back through those patients who have been unable to have face-to-face care and actually getting in touch with them and saying, okay, how are you? Do we need to see you? And sort of prioritizing those with the most problems. But we're still a long way away from anything that we consider routine at the moment.
Okay, thanks for that, Tom. Next, Co-optee June Ball.
Thank you, Madam Chair. Thank you, David, and thank you, Tom. Can one of you reiterate how many NHS dental practices there happens to be in Peterborough? And we've read in the papers, particularly pages 44 and 45, that all dental practices with an NHS contract were expected to give advice, analgesics and antibiotics. But if someone wasn't or isn't registered as an NHS dental, isn't registered at a practice that is part of the NHS, how did they actually fare during the initial pandemic?
So maybe I can talk to that point first of all, if I may. So for many years now, unlike GPs where they have registered patient lists, dental practices don't have registered lists. And as anybody presents at a dental practice prior to COVID, if the dental practice had the right amount of contracted activity, they should see any patient that presents for a course of treatment. And just because a patient has a course of treatment and that is their regular dental practice, as the patient may see it, they're still not registered at that practice. And so, but what it does mean is that any patient can go to any NHS primary care dental practice and seek treatment. And if that practice has the availability to see the patient, then the patient should be seen. So that's kind of just to help an understanding of the base level of what did happen pre-COVID. Currently now we're in a situation where we're working robustly with all practices across the whole region to be able to mobilise safely and securely, both for the dental team and for patients. And so all of our practices, the 600 or so throughout the region, have been open. It's just during that phase from March 25th to the 8th of June, they weren't able to physically see patients, but they were open remotely to be able to take phone calls and be able to assist patients. And those patients that met that higher bar that Tom spoke about would have been referred on to one of the urgent dental care centre hubs for face-to-face treatment, whether that was non-AGP procedure or indeed AGP procedure using the right PPE3 level protection. Perhaps, Tom, would you like to add anything more to that?
Yeah, thanks, David. And I suppose in regards to those patients who don't have a regular dentist, we set up a variety of sort of safety nets, I suppose. The first is, as David quite rightly said, anybody could present to any practice, and they did. My practice was doing virtual ward rounds. Anybody was phoning up, and we had numerous dentists on the end of phones, sort of using a system called CryCare, which is like a Skype thing where you send the patient a text and they'd log in and you have a chat with them. There are various different systems out there, and so patients were able to speak to any of our team, and they were from all over the place. People get numbers of dentists from anywhere, so that was available, and lots of practices were doing that, very open. Also, we had NHS 111. NHS 111 got a lot of extra dental calls, but they could either send to a practice, and any of those practices, and NHS 111 team would say, okay, you can link to these practices in your area, or any of these practices. And then we also had a fail-safe system where patients were also getting through to this CTS, this clinical triaging group of dentists. So numerous dentists sat in their home, like I am now, with a phone or computer in front of them, working sort of 12, 14, 16-hour shifts, just one after another, getting through this list of referrals or patients and contacts that were coming through. In addition, we also realized the out-of-hours system needed bolstering. So we bolstered the out-of-hours system by some of these urgent dental care centres opening at the weekends as well, all day Saturday, all day Sunday, and we still got that in place. So that's just a safety net to ensure that if patients need it, they can get face-to-face. And so those were things. And of course, patients were presenting to hospitals, so they were coming into the systems that way. There were all sorts of ways, GPs, you name it, patients were coming in all sorts of ways, and everything went through this central triaging system, which allowed us to prioritize the most urgent pain, the ones with spreading infection through their head, the trauma cases, the significant stuff.
Can I just ask a supplementary? Did that include orthodontic treatment?
It did. So orthodontics was included within the UDC. So there was a lot of guidance, because orthodontics, it's very difficult to see orthodontics as being an urgent problem, anything more than sort of a mediocre urgent problem. Certainly it doesn't get into the emergency category. So a broken brace, there's nothing urgent about a broken brace, but there were a few occasions where wires stick into cheeks, and so a lot of the orthodontists again were offering this remote system where they do a video conference like this and explain to one of the parents how to pull the wire out from the child's brace to remove the problem. As soon as you remove the wire, the problem more or less goes in these cases. But there are one or two occasions when it was different, and in which case the orthodontist came into a practice. For example, my practice, an orthodontist came in a couple of times to treat his patient because one of them needed to have a sort of brain scan because of thought they had a tumor, and you've got to take the metal appliance off because otherwise it messes up the MRI image. So there was that, and there were various other obscure things that we took. So each case was looked on a case-by-case basis with all clinicians being involved, lots of phone calls, lots of video conferencing, lots of WhatsApping, pull things together. It worked. And the chief, as David quite rightly said, we were in this region, we were hot off the press very quickly, and the chief dental officer very publicly announced and said how proud she was of the East of England. So we got a little pat on the back there right in the middle of the crisis, which at the time was a tough time, as I'm sure we all.
Okay, so then there's Councillor Kayem.
Thank you, Madam Chair. I'd like to ask, what have you been doing about community-based patients who have been requiring dental care? The reason why I ask is, as a GP, I have had quite a high volume of people requiring urgent dental care, asking me for antibiotics because, and this is just feedback, it's not criticism, because they have been turned away by the NHS 111 dental service, saying that they cannot be accommodated. And indeed, I've also, in a councillor capacity, been approached by residents who know I'm a GP to give them some advice on what best they could do. I have been signposting them to NHS 111, but in particular, I've been worried about a handful of patients that are housebound and were in receipt of community dental care, if that's a thing, I'm not too sure. And I've had a few patients that have been in absolute agony with dental pain, and because of their disabilities have been unable to leave the house. They have been shielding and vulnerable, but had to live with this pain. And the best I could do was give them analgesia, which hasn't really solved the problem. What have you done with those particular group of patients?
Thank you. That's a very, very good question. So community dental services deal specifically with vulnerable children and adults and patients that are in that category that need, so even before COVID, they needed additional time within the dental surgery and additional chair time with specialists who were able to deal with not only their dental conditions, but any other associated maladies or concerns the patient would present with. And so we've had CDS providers act as urgent dental care centres as well. So Tom mentioned the central triage system. So anything that would be coming in from any kind of referrals that would come via GPs, via 111, or however, or through other dental practices, where we had an understanding that the patient needed additional support, they were referred, if appropriate, and if they met the bar, to CDS providers who were also providing UDC, urgent dental care centre provision as well during that period in time. So I think the robustness was that we had this 60 or 70 dentists who weren't able to practice in their practices, who volunteered to spend many hours a day looking at all of the referrals and making sure that each referral went to the most appropriate outcome for that patient.
Thank you. How would we have been signposted to that service? Because someone like myself, another professional, wasn't made aware as a GP.
So the gateway into the services was through 111 or from a dental practice referring into the central triage system. And they were the main gateways into those systems. And GPs, pharmacies, opticians, all of the other primary care providers were clearly provided with the kind of signposting for patients, for dental patients. So even if GPs or pharmacies had, or even opticians had patients that would pitch up complaining of dental pain, they would be able to signpost the patient either to their regular dentist or to 111. It would then go into the central triage system, this 60 or 70 dentists who would look at each and every single case and work out what was most appropriate for the treatment of that patient. Because the bar was raised, many patients weren't able to see a dentist face-to-face. In fact, we had, and Tom, who's a clinician, could probably talk to this, some patients weren't signposted through to face-to-face services because it would have actually put the patient more at risk if they needed to go into, say, a hospital setting for treatment. Then you have to clinically work that out. But maybe I could invite Tom to talk to that part of the question.
Yeah, I mean, you're right, David, that a lot of these patients are very vulnerable, and we're shielding. And initially, we needed the correct PPE. This COVID crisis hit everybody, pretty quickly. And therefore, if you've got a standard mask, so we use what is called level 3 PPE, which David highlighted earlier, which is I suppose the gold standard is what is called an FFP3 mask, which filters 99% of viruses. And the initial masks that we were getting through the supply chain, which was very tough to start off with. PPE wasn't everywhere to start off with. As a GP, I'm sure you've got colleagues working in hospital trying to get FFP3 masks. Is quite difficult, and therefore, most of them had filters, a little block at the front, which means that, of course, as the clinician, as you breathe out, you're in somebody's home, then you're breathing out potentially. You could be infected, and clinicians, particularly dentists, we know in the early stages of the COVID crisis, were getting COVID in very high numbers. Initially in London, but also across the country, because when people were symptom free, they were getting it. So the thought was that dentists and dental nurses could be super spreaders, and therefore going into people's houses, particularly if they're vulnerable or seeing vulnerable patients, you put them at risk of getting COVID. You might be wanting to sort their pain out and improve things, but in reality, you're not helping them. So we had to tread incredibly carefully on a very, very carefully risk assessed basis, and it could take a couple of hours to risk assess these patients, get in touch with their GP, speaking to hospitals, deciding, is it worth it or not going in, and can we control their pain remotely? And that's a lot of what we were doing, remotely controlling pain. So it was very difficult, and it still is. It's not easy, but it's we're widening out. These patients are being contacted. Are you still in pain? What can we do about it? And it's more controlled now.
Thank you.
Okay, I'm just conscious of time, and we're sort of beginning to run over. I've got 3 questions left, so if we can try and keep the questions and answers sort of fairly brief. So, Councillor Hemraj.
It's really, if your dentist services were provided with better PPE, i.e. the FFP3 masks and the full gowns and shields at the start of the pandemic, would you still been able to provide a better dental service than going through to the 2 dental services for urgent care? Thank you.
Tom, would you like to answer that? It's clinically based.
Yeah, I think to start off with, it wouldn't have made a great deal of difference. And I have to say, we were very fortunate in this region. We got NHS England pulled a really good team together of people who were sourcing PPE, and so they were getting significant amounts for us. So all the UDCs had all the PPE they needed. Level 3 PPE. So we're talking about the heavy duty stuff, the gowns that you'd use in hospital, the theatre gowns, the respirators, the sort of FFP3 masks. They were getting all of that, enough for what we needed. And so there was no limit on us actually picking the number of UDCs. We chose as many UDCs as we wanted to. Not everybody agreed to do it because some of their team were vulnerable. Right at the beginning, there were team members who went down with COVID. People were scared. There was a lot of uncertainty. So it was a very, very gentle process. But PP wasn't necessarily the limiting factor in opening. It was always a scare, and we were always talking about it. But we had a very good team, a group of people who were doing nothing else but sourcing PPE for us. And we had fit testers, so we had the kit to test that the seal was good. And so yeah, we were comfortable. We got a big system up and running very early on, and we had sort of teams of people devoted to PPE and nothing else but sourcing PPE.
Okay, can I just ask a supplementary question?
Yeah, sure.
So you had the number of PPE, okay, at the start of the service, and I understand about people being scared because myself an NHS worker got COVID myself. But as you had this amount of PPE, why did you feel the need just to only have 2 dental services open to provide the most urgent care that for those patients that needed that treatment, and the rest of those patients had to basically suffer until June until a dentist actually opened to treat them?
So perhaps I can answer that. So it was the Office of the Chief Dental Officer that made the decision to obviously suspend regular routine dental services to patients. There's also an issue. If you look at the pre-COVID times, a dentist maybe routinely would see 20, 30 patients in a day, and they would appropriately clean down between each patient. Currently now, if it's an aerosol generated procedure, the actual surgery needs to lie fallow for up to an hour before even being cleaned down. So a dentist now would only be able to see 4 or 5 patients, maybe 6 patients in a day, with obviously that hour to allow the aerosol to settle, and then, you know, cleaning time as well, plus social distancing measures as well. So I think overall, one of the places where COVID would have spread most rapidly would be in a dental practice that produces aerosols, the right size particles that carry COVID, that people could just readily breathe in. And all of a sudden you could have a situation where there was a super spread just by going to the dentist. So again, I guess decisions were made following guidance from Public Health England, because we follow their guidance in terms of what is appropriate. So yes, we acknowledge it's not great for patients, because I don't want any patient to have to be in pain longer than they need to be. However, that had to be balanced up with the guidance from Public Health England and from the Office of the Chief Dental Officer to make sure that that what is being done is safe. And that's the case now. As these practices start to open, they have to make sure that it's safe for patients and for the dental team, and that we don't inadvertently spread COVID.
Okay, thank you.
Okay, Councillor Sanford.
Thank you, Madam Chairman. I've got 2 questions. Because I'm really pleased that we've got this item on the agenda. I was one of those who requested it, because I was hearing a lot of stories in the press and also anecdotally from people that I spoke to, that I think the people talking to us have talked about, you know, the bar being put higher, and what that was meaning was the only cases that were getting referred through to the urgent treatment centres were people in really severe situations, and that people who were actually in pain weren't getting referred. So I do find it really surprising that you didn't get any complaints. And I think Councillor Farrer, right back at the beginning, asked the question, well, how would somebody have made a complaint? And we didn't really get an answer to that. So could that be addressed? And also, you know, given the fact there is some talk and some speculation that in the autumn we may get a further spike in COVID cases, are we actually going to be equipping all the dental practices so that they can see all their patients? Because I do think that's the optimal situation where a patient could, you know, go to their normal dentist and sort of get the full range of treatments.
Thank you. Maybe I can answer your second question first. So the urgent dental care centres that were put in place will stay in place. And as other dental practices open up, yes, they will eventually be providing AGP level services to their patients and patients that choose to see them. And then I guess if there is a second spike of COVID, or even in areas, you know, we've seen the situation in Leicester just recently, If there is, then of course the practices would need to follow the advice of Public Health England. But one would assume if they have the right levels of PPE and they can socially distance appropriately, then patients could be seen. But again, we would be led by Public Health England, who would weigh up the risks for patients in attending a dentist versus the treatment that they need to get out of pain. In terms of your first question, any individual that would wish to raise concerns with NHS services can do so in many ways. They can do it with the practice that they're contacting, or they can go through the NHS contact us system to log their complaint if they don't want to complain directly to a particular provider or practice. And they would be able, those complaints would be logged and they would come through to our team to look at, to see what could be done, first of all, to help the patient, and then secondly, to answer their concerns.
Okay, just coming back on one further question. What impact is this going to have on the dental health of the population in Peterborough? Because those of us who have been on the committee for a while, we went to the dental access centre and we were being told there that they were being swamped by cases and not able to handle all the cases that we were receiving. And so we're now being told that, you know, that a lot of the dentists have opened, but they can only provide a limited range of services and only see a limited number of patients. So how long is it going to take for us to get back to a normal situation?
Okay, perhaps I can invite Tom to talk to that question.
Yeah, I mean, Councillor, it's a good point. As in reality, as dentists, we've been fighting to get people to come and see us and improve prevention and access for years, and this is going to be a bit of a knock. But the positive sign is that, you know, at the moment we're talking about reviewing all these services and how do we bring the prevention and the oral health education and all the sort of other stuff we've been doing, how do we bring it back? So those services are being spoken about and how we sort of bring them back, and I think they will. I think everything will come back on board. I mean, the other thing we've noticed is that the number of patients being referred into the UDCs isn't, you know, it's not overwhelming at the moment. It's certainly manageable. You know, there's capacity most days, you know, to see the most urgent. So there's not a system where we're having to shut them down. They can switch themselves off if they get overwhelmed, but they're not doing that. And it didn't happen very often, even right in the middle of the crisis. You know, so I think the situation is manageable at the moment. We feel quite comfortable about it. But, you know, as David mentioned, Public Health England, we work very closely with Public Health England, and they've got a lot of priorities that are working well with NHS England as well, which is improving dental health, how we sort of reach out to other communities, improve inequalities, all those sort of agenda items, and we're working on those. We're working at plans to develop that as we move forward into the new NHS arena and the new dental service, which we think is probably going to come out of this.
Maybe I could just add to that, Chair, if I may.
Sure.
Before COVID started, we had started a pilot system for oral health stabilisation. So above a dentist's normal contract, if they had a patient walk in who was in abject pain with their tooth, they, unlike the walk-in centre where they would just go in and get a very good service and have that tooth sorted out, we were linking with all dental practices who wished to do so to be able to remunerate them above their contract for the extra chair time that it would take, not only to have that patient come in and have the urgent situation sorted out, the pain that they're in, but also to look at the stabilising their oral health and all the other kind of oral concerns that patient might have had, so that it would build a professional relationship of trust with that patient, and they would feel able to come back again and again and again to be able to improve their oral health, rather than just a situation of walking into a centre, becoming pain-free, and then not worrying about their oral health well-being for many months or years again until the problem erupts in another tooth on the other side of the mouth. So that was a really good pilot that we had started off. And as we start to come out of COVID, we'd invite practices to start delivering that to the population.
Thank you, David. So, Councillor Fowler.
Thank you, Chair. I did a little online check via the NHS website before this meeting, and of course I am aware of the pandemic, but things weren't great before March this year, and well, I discovered that, as an example, anyone in, say, Gunthorpe, Walton, Paston, Warrington, they would discover that about 90% of dentists in Peterborough are not taking new NHS patients, or said only by referral from a dental practitioner. Now, for the public record, I wonder if you could explain what that actually means and how somebody gets such a referral. Plus, some practitioners hadn't even provided up-to-date information for the last 90 days. And I'd like to add that given practices opened over a month ago, I'd be intrigued to know what effort has been made to assess their success, number of new patients accepted, specifically NHS patients, etc. And going forward, and noting CV19 isn't going away, what actions will be taken to ensure access to NHS dentistry is not an impossibility for hard-working peeps in Peterborough? Thank you.
Thank you. Good question. So we are in a COVID-19 situation, and practices are reopening appropriately where they can see patients clinically appropriately. And so I guess if one of your constituents in Peterborough wished to go to a dental practice, it would be determinant on what their needs were. If it was for a routine checkup, maybe a clinical decision would be made that that isn't appropriate in that particular practice at that time. So there are varying levels of things that need to be taken into consideration. Obviously, our aspiration is to have all of the practices fully reopen and to see as many patients as they possibly can, and to attract other patients through the oral health stabilisation programme that we have running as well, so that they're able to take on additional patients. Maybe I could ask Tom just to add to the answer a little bit more.
Yeah, and I think we need to highlight that we're still in the COVID world, as David said. You know, we've Leicester, not a million miles away, is having problems, and I think, you know, we're sort of thinking about how we deal with second waves, third waves, that sort of thing. So practices aren't opening up to do checkups. You know, as David said, it's not there. My practice is not. We're seeing lots of patients, but we're not routinely offering checkups unless you're about to start chemotherapy or you've got some underlying medical need. We're sort of limiting it to those people who need it the most at the moment. So I think, you know, if you phoned round, if you looked at most practices, you're not going to get a yes, book an appointment tomorrow or next week for a checkup. It's not that sort of world yet. But if you contacted a practice and said, I'm in pain, I'm struggling, I think you'll probably find you get a better response. With regards to the filling out of the NHS data, a lot of practices have had a lot to do. And the idea that, you know, I suppose the idea of saying, yes, we're open to practices to see patients, to see anybody, I think most practices are actually just saying, we need to just see those that we can do. So a lot of practices are still not up to full steam yet as far as doing AGPs. They're still doing non-AGP work because of how they're feeling with regards to the team, safety, whether they've got all the PPE in the right place, whether they've got the procedures ready, that sort of thing. It's only, the Chief Dental Officer said you can start from the 8th. She didn't say you had to be going from the 8th. But most of our practices are there or heading that way. And yes, you asked in regards to receiving patients on referral, they will be practices where they'll say, okay, I'll accept a patient who needs more care, a different level of care or a higher level of care. So that might be root canal treatment, that might be orthodontic treatment, that might be oral surgery treatment. And so practices are starting to head that way of actually saying these are the priorities, but also it might well be someone in pain as well. So 111 can phone up and do highlight practices to patients so that they can get treatment. And as David
just a supplementary question, please, Chair. Thank you very much for that very full answer. I do try and maintain my foot in the realms of reality and everyday life, which is can be testing, as you can imagine. I understand that the problems that you guys are facing. However, I'm also mindful that we've got potentially some people out there, key workers, essential workers, however you want to title them, and they may be in such pain that it might not necessarily be a priority overall, but it could prevent them from potentially actually going and doing their jobs, carrying on everyday life. So, I mean, is there any scheme in place to help those types of people, or are there any plans in place to essentially say to people who are on the front line, if you have got a situation with your teeth that is so unbearable that's preventing you from work, etc., that they can somehow be edged to the front of the queue or dealt with as soon as possible?
I think any patient that was in unbearable pain that was affecting their life, then being able to work, whether it's just to provide for their family or work because they're considered a key worker, they would go through the triaging system, and you would find that they would be assisted in one of the urgent dental care centres to help them get out of pain. And thereafter, they'd probably go back to a more regular practice for oral health stabilisation when that's appropriate.
Okay, so it looks like we've come to the end of our questions for this particular paper. The recommendation is that we note the contents of the report for information, and if anybody has any objections to that, if you can just put your hands up. Okay, then basically we'll note the report. Thank David, Tom and Jessica for attending the meeting and joining us and informing us on sort of the dentistry area as far as COVID-19 is concerned. We really appreciate you coming along. So thank you very much for that. That basically brings us to the end of our meeting. Just want to say thank you to our Democratic Services team for helping me through the meeting tonight, being the first virtual health scrutiny. I couldn't have done it without you. So thank you, and I will see you all in September for our next meeting.